Good afternoon, everybody, and it's my distinct pleasure to introduce the next presenter, Dr. Butter. He will speak about the direct and indirect molecular effect of CCM, how is myocardial function improved. I think it's quite important to understand the mechanistic and really the molecular basis for what Dr. Hasenfuss just presented.
Dear Angelo, dear Martin, dear colleagues, it's a pleasure and honor to be here, and I will try to explain how we today believe that CCM works, which is not obviously that easy to understand, but I will try to support my explanations by animal and human data. This is my conflict of interest. We all know that heart failure has an impact on several proteins and as well as on neurohumoral stress. So we know that that results in a protein dysfunction, that we have an altered amount and types of protein which changes in the myocardium. And finally, these effects have a progressive negative impact on the LV function, which results in an LV remodeling, which is the consequence of any reason of heart failure. And following by this, this kind of LV remodeling, stress myocardial cells switch into fetal gene program. Stress genes are overexpressed, and we believe right now that CCM reverses the fetal gene program to the normal gene program. And I will try to explain why I believe that it is that way. Currently, we are convinced that it's not one step. It's different to CRT, where we see immediately, just beat by beat, an improvement of LV contractility. In CCM, it's probably several steps which are needed to result in a reverse remodeling. First, which happens within a few seconds, is the impact on the regulatory proteins. That means that the phosphorization of phospholamban is changed immediately. Not the overall amount of phospholamban, but the portion of the phosphorylated part, which is the important portion to stimulate SERCA2A. And after hours, we will see that gene expression will be changed, and the final output, which every cardiologist will see, is a reverse remodeling. That means that the dimension of the left ventricle and diastolic and systolic diameters are improved after that kind of therapy. Professor Hasenfuss has already mentioned with a few words how CCM is applied. That's extremely important to understand the mechanism. You all know that we need 3 leads for that kind of therapy, 1 atrial lead and 2 ventricular leads. Those ventricular leads are fixed in the RV septum from the right heart. So those are screw-in leads with a larger surface of the tip. Usually one is implanted close to the outflow tract, and the lower one in the mid-right ventricular septum. So we create an area which is usually between 4 and 7 centimeters, where we induce electronic conduction, which seems to be very regional. And at that area, we induce the phosphorization of phospholamban, and we believe that we restore a cellular function at that area, and we improve contractile force directly in the area of application. How can we prove that? We can show that in animal data in a dog model from the working group of Tony Sabat in Detroit. You see on the left the normal dog with phospholamban and the phosphorylated portion of the phospholamban on the upper row. You see that it's down-regulated in heart failure, both parts, the phosphorylated part as well as overall. And after application of CCM, you see that the phosphorylated portion is upregulated again and will be close to the normal density, which is measured in the Western blot test. If you move just to isolated cells and apply CCM for a few seconds, you can see that just applied 10, 20, 30, and 60 seconds, it increases over the period, but you see an onset of induction of phosphorylation within a few seconds. That's important. Those samples, those are isolated cells. In the previous slide, the samples are very close, taken from the area of application of CCM. How can we show that the fetal gene program is removed to a normal one? Those are data also from a dog model of heart failure. You see on the left side the normals. Just look for ANP, for example BNP, maybe phospholamban, alpha-myosin heavy chains. You see what is going on in the heart failure sham portion. Those are the dogs which are not treated by CCM. You see in the middle. You see that ANP and BNP are upregulated as an index for increased heart failure. Alpha-myosin heavy chain are downregulated. And after treatment, you see, for example, ANP and BNP in downregulation, which means a normalization of those fetal gene program. For example, if you look for protein expression of SERCA2A, which plays an important role in the calcium handling of the heart failure heart, you see, for example, gene expression of SERCA2A on the left. You see normal, higher density. It's completely downregulated in heart failure and improves afterwards after a period of CCM application. We have controlled that in patients. Just to explain that more or less complex slide. The arrows show the direction in which heart failure, the genes should improve after treatment. So that means that if heart failure improves, for example, on the ANP, BNP, the first two bars should be reduced. These patients have been part of the FIX-HF4 trial, which was a 3-month crossover trial, 3 months on, 3 months off, or 3 months off, and then on blinded turned over. And what you nicely can see in the period where the patients received no CCM therapy, so those are the yellow portion of the bars, all patients deteriorated in their gene program. As soon as you start pacing maybe it's not stimulating, it's better, it's not pacing in a way, you start stimulating, you see a direct movement in all measured gene programs, also, for example, RI or P21, for example, all have been developing, moving in the correct direction, which shows that we can restore or improve cardiac function in those gene programs in a blinded crossover way. That's the first period. What happens then? Somehow, the whole left ventricle has to be affected. We are just stimulating the RV septum. But what we like to see and what we see in DPDT measurements is an improvement of global contractility of the left ventricle. So how is the whole left ventricle affected? We are not sure whether it's just by improving contractility in the septal part, unloading the left posterolateral portion, or whether it's mainly due to electronic coupling by the gap junction. That is unknown, but I can show you that the remote wall is also affected. Those are acute data right here in a very short period of pacing. You see on the left part of the slide that near the stimulation site after CCM, you see SERCA2A expression is increased. That means improved again. If you take samples, acutely samples from the remote side, which means not the side of the left ventricle where the stimulation is, that's the posterolateral wall, you see no effect in that area at all. But if you continue, for example, for 3 months, the effect on SERCA2A has moved to the posterolateral, which means the remote wall, so the whole left ventricle seems to be affected by CCM therapy. And after all, we hope to see the reverse remodeling. That means after inducing those molecular protein changes, we might end up with a reverse remodeling. That means a reduction of end diastolic volume as seen here in animals, in the dog model, in a 3D measurement. You see an increase of ejection fraction on the right bar and a reduction of end diastolic and systolic volume. Those data has been proved and supported by human data by the working group of you in 2009, published in JACC Cardiovascular Imaging, which directly moves into the same direction. How does it work? Why does it work? I think it's important at which time of the ECG or of the plateau phase the signals are delivered. The action potential has in its plateau phase an extremely increased opening for the transmembrane ion channels, and directly in that period the CCM signals are delivered. So that's important, and you cannot just put those signals somewhere. So those electromagnetic fields shown by the Brooklyn Journal of Cell Physiology by Blank have different consequences. They induce enzyme reactions, oxidation, reduction, reaction rate, and even transcription of DNR. That's something which is already known by electromagnetic fields, and those fields are delivered to the heart by CCM. So if we try to summarize, we have two periods. We have a time course of progression, which happens within seconds. That's the phosphorylation. After hours, we see the gene expression, and after months, what everybody hopes to see in its cardiological practice or in the hospital is reverse remodeling. And we start with a very small area close to the two right ventricular septal leads. Then you get the unloading of the remote area and the expansion to the whole left ventricle, which finally ends up in the global reverse remodeling. I would like to maybe turn over afterwards to Martin Bockgrafe with some data. The question is, do these changes really influence survival? We have no study until now which has ever looked on survival on a long-term period. So we just took our patients, which have been 55 patients, 54 patients who have been followed from 2003 up to 2010, and you can see the demographics on the right side, mean age 63. It's important, this has been very, very sick patients. Nearly 30% of them were not able to perform CPX. So we have a mean VO2 of 10 milliliters per kilogram, and if you look for the NT-proBNP, a mean value of close to 5,000 units. So they have been followed for quite a while. CCM has been delivered in the median time of 660 days, so nearly 2 years delivery. And if you look for mortality, we see an annual mortality rate of all-cause mortality, which is 18%. Cardiac mortality is 17%, which is comparable to CRT trials in those severe heart failure patients. What we are interested to know, we try to figure out whether those patients live longer if we compare them with a heart failure model which is accepted. An accepted heart failure model, scoring model, is a Seattle heart failure score, which adds several laboratory parameters, comorbidity, something else, and we put all our data in and we compare them, and you see that CCM mortality is exactly like the predicted mortality without the device of the Seattle heart failure. Now you would say, okay, then it's not better, but on the other hand, you can argue it's safe, it does not put any risk on the patients, but the patients will have at least a few years of better quality of life, which has been shown in previous studies. Thank you.